Welcome to Grow Them Right, podcast where we discuss how to prevent health issues from infancy. I'm Dr. Roche, a dentist and a mother of two. As a dentist, my expertise are in oral health, and I'm committed to continuing education. I also have a keen interest in preventative health. So in this podcast, I ask questions of experts, explore their insights, and discuss practical tips on how we can help our children grow healthy and strong right from the start. The whole idea for this podcast is to elevate the conversation and allow you, the listener, to make more informed decisions. I need to emphasize that these podcasts are not a substitute for medical advice. If you have any specific health concerns for you or your loved ones, please speak to your own medical professionals. I hope you find this space useful, and if you do, please take a second to subscribe and share with your friends. And together, let's grow them right. One of the most fundamental aspects of health is good sleep, and parents often wonder if their kids are getting the proper quality and quantity of the sleep they need. How does poor sleep affect children, and how can we take steps to improve this very important aspect of their health? To discuss this, I'm honored to have Associate Professor Andrew Tai here. Andrew is a pediatric respiratory and sleep physician, the head of the department at the Women and Children's Hospital, as well as a professor of medicine at the University of Adelaide. He has taken time out of his very busy schedule today to discuss with me, when it comes to our children's health, how can we grow them right? Thank you for joining me, Andrew.
Good morning.
So to start with, tell us a little bit about yourself and your journey.
Yeah, so I grew up in a country called Malaysia, and my family migrated to Australia when I was in early adolescence, and I've done my high schooling and my medical degree in Adelaide. And I then spent a few years doing a higher degree, a PhD in Melbourne, and then returned back to Australia, in Adelaide back in 2010, where I was fortunate to have a posting as a pediatric respiratory and sleep specialist at the Women's and Children's Hospital. And I've always had a passion in breathing disorders as well as sleeping disorders, which is the reason why I chose this area of specialty in my own training.
Fantastic. So you're a pediatric respiratory and sleep physician. Why is sleep important in health of a child?
Yeah, I mean, if you think about what we all do, is a third of our life we spend sleeping. So clearly sleep has a significant biological impact on how we function day to day. So if you just break down into simple terms, why is sleep so important? For me, there are probably 3 or 4 main reasons. The first one is really in helping the body repair. So when we go to sleep, the body goes through a process of repair. So if there's any areas where there's physical hurt or emotional hurt, the body has a capacity to repair itself. The second big area for me is your immune system. So we know that healthy sleep promotes good function of your immunity, again, which helps very much in that healing from any illnesses or any broken skin, for example, anything that would require healing. That's where the body functions. And I think the most important area is in the function of your learning capacity. Sleep is very much so important in things like your memory retention, your thinking and planning thoughts, and also your emotional regulation. So it's quite common when you see children who don't get sufficient sleep, you see those areas of emotional dysregulation or even worst case, their inability to concentrate well in their studies, affecting their daytime function. So that's really, I think, for me, the 3 main factors as to why I would say that sleep is so important for children as it is would be in adults as well.
So a big link to mental health, good sleep and
absolutely, yes,
behavior.
Yes.
So do you see a link perhaps between a lack of sleep or poor sleep and symptoms that mimic ADHD?
Yes, definitely. I mean, that's one of the important screening questions we would definitely ask when there is a concern about a child who is playing up at school or is having issues of inattention or hyperactivity, which is that domain of that ADHD that you hear about quite commonly through the schools. It's really important for the parents to have a chat to their healthcare practitioner and to really reflect as to whether there's any issues that could be originating from a lack of sleep or poor quality sleep, which can be manifesting in those daytime symptoms.
Incredible. Is there a difference between a child's sleep and an adult sleep?
Yes, very much so. Sleep is just very basic. There are 2 kind of phases of sleep. What we call, there's those periods when you have what's called light to deep sleep. And then there's another part of sleep that we call REM, or people shorten that to REM sleep, where there are times when you have dreaming and things like those things happen during those phases of sleep. So what happens in babies is they spend half their life in that kind of non-REM or the light to deep sleep, and then half their life in REM sleep. And as this child progresses through toddler life and then into childhood and then into adult life, what we see is a reduction in the total REM sleep. So REM sleep in a child from the age of 6 into adolescents and adults will probably be between 20 to 25% of the total sleep, which majority of that sleep is then represented by that non-REM or the light and deep sleep. And the reason why that's important to know is that when we see any abnormalities of sleep, it typically tends to occur during that REM or the REM phase of sleep.
Interesting.
Yeah, and the reason for that is that during those periods of REM sleep, the muscles that hold our airway open, in essence, go to sleep.
Paralyzed.
So there's a loss of tone in the muscles that control and open our airways. So if there's any disorders that occur, particularly in children, it is more common to occur during those early years of life because they spend more time in the REM phase of sleep.
And REM is important. I've read that it's because it is to do with emotional regulation and also growth of the brain. Brain cells grow during REM sleep. Is that accurate statement?
Yeah, I think there's the brain is such a complex organ, and we need those all cycles of sleep. So a healthy sleep cycle for a child and an adult would cycle through the non-REM as well as the REM sleep. So that's how you go through a real period of rest when you can go through the whole cycle of sleep. And then those cycles of sleep, would last between 60 to 90 minutes. So that's why you hear in young moms who have little babies, they're always hoping for their child to have that, 45, 60-minute nap or even the hour-and-a-half nap, because generally it's during those phases that the child's gone through those full cycles of sleep, through the non-REM and then the REM sleep. And I think that the REM sleep is really, where a lot of that consolidation of those things that I mentioned about around the brain optimization of memory recall, task acquisition, all those things, are probably consolidated within, the whole healthy sleep cycle.
What should parents look for if they think that their child isn't getting enough quality sleep? What are some of the signs?
Yeah, absolutely. So I think the things to be really mindful of is how well they feel during the next day. So one thing I say about sleep is that, there's a lot of interest around how much sleep is enough for your child. And as a parent myself,
that's right.
You're always wanting to ensure that your child has sufficient sleep. And there is a big range in terms of what is considered as normal sleep.
Normal or sufficient, yes.
That's right. So obviously babies spend most of their time asleep, so it's not it's common for babies to spend 16 hours asleep during the day. And clearly as the baby grows into their toddler life, that sleep requirements may drop to between 12 to 14 hours. It's a bit of a range. And then when they start schooling, obviously school has a routine. So again, I would expect during primary school, a child would need between 10 to 12 hours of sleep. And then obviously as we go into those adolescent years, when there are other distractions in life, sleep requirements may drop in that age group to be between 8 to 10 hours of sleep. But I think irrespective of how many hours the child has, I think one of the key things I always ask my parents is, in the next morning, did your child wake up him or herself? Or did you physically need to go and rock him and shake them and wake them up? Because if they're able to generally wake up themselves, it is likely that their body has had sufficient sleep. But importantly, like I said, lack of sleep or poor quality sleep will then play itself out during the day. So I think a lot of those warning signs, the very grumpy child, the child who's struggling to concentrate during the day, they just obviously appear very sleepy and tired, and
hyperactive.
Absolutely,
Because adults become lethargic and tired. And children do the opposite; they become hyperactive.
They can be quite hyperactive, And this is where sometimes that there is that confusion between, is this that behavioral issues of ADHD, or is this a poor sleep that's causing them to be hyperactive? So I think very much so it's important to also get feedback from the teachers at school. Because generally that's where they're spending the most of their days. And the teachers are good at spotting these things. They'll generally flag it with parents. Your child's playing up, or your child just appears so tired and sleepy. Or the other extreme case, they're really hyperactive and just unable to concentrate and focus on their task. So I think they're the real key warning signs to look for.
And teachers are often quite informed about signs of ADHD, but probably less informed about that this might be from lack of sleep.
Yes, that's right. I think they see this this child that's misbehaving or hyperactive, and obviously they would alert that to the parents. But I think importantly, that's when a parent should take their child to their again their primary healthcare practitioner, just to get them checked up, and importantly within that is to reflect on sleep, particularly the total amount of sleep and also hopefully the quality of the sleep.
Yes, and I think this is really important to raise that awareness that this could be from sleep. So then the point is that the length of the sleep matters, but also the quality of that sleep also matters, because sometimes parents say, oh, my child sleeps really well, from 7 to 7. But then when you ask, is your child refreshed and behaving and performing and functioning well, then that becomes a different question. Okay, so we talked about sleep apnea. Can you tell us a little bit about what that phenomenon is?
Yeah, so sleep apnea is a condition where there is essentially some narrowing within your windpipe. And when I say the word windpipe, I mean from your nose that goes all the way down into your kind of breathing tracts. So if there's any narrowing within, that windpipe, what then happens is that as you breathe in, there is a obstruction or narrowing that causes the obstruction, and you get essentially what's called turbulence of air going through your windpipe. That presents in a common symptom that we call a snore, because there's vibrations of the muscles and the tissues surrounding that. And the snoring is, I guess, one of the main symptoms that we look for sleep apnea. So basically what sleep apnea then entails is that those muscles that I mentioned that keep your airways open essentially close over during particularly those REM phases of sleep. And as such, there is a reduction of air that goes from your nose into your airways, and that then reflects in those poor quality sleep.
So is it that the brain wakes the individual up to breathe if they obstruct?
Absolutely, yes. So basically when you have those obstruction, and you're not breathing, the brain will send a signal and say, hey, you need to take a breath.
And it's a stress signal, so you are more likely to be in fight and flight.
Yeah, so there's a surge of what we call adrenaline and those things, so that will trigger this response that we call an arousal. So the brain makes this response. So in a child, what you will see, or in an adult, you'll see what's called gasping breath. So you'll see them snoring, and then suddenly there is a pause in their breathing. And then they show this gasping breath as if they're struggling to get air in.
And that has profound impact on general health, doesn't it?
Yes, very much so. So obstructive sleep apnea is a reasonably common condition in childhood. Studies report anywhere between 2 to 5% in childhood. But when you look at snoring as a symptom, we see that more in up to 15% of children. But sleep apnea, if it's left unrecognized and untreated, it can definitely have some unfortunate consequences. And the main ones typically center around, again, the concentration ability of the child, which affects in their learning capacity. It can also affect their behavior that we mentioned about. So
metabolic health?
Yeah, the metabolic health. So we know that as children unrecognized, it can put a strain on their heart potentially as well. So there's some studies that show that your blood pressure may be elevated in a child and adolescent and adult. So they're one of the screening signs that health practitioners should be looking for if the blood pressure is elevated. Just again to think about whether sleep apnea could be contributing to that.
So this is a spectrum of disease. So sleep disordered breathing starts from maybe mouth breathing, maybe tossing and turning and restless sleep, and all the way to obstruction, sleep apnea, and then goes through mild, moderate, and severe. So do we need to worry about the entire spectrum? Or do we just deal with it when it reaches those mild or moderate stages?
Yeah, I think it's a great question, Rosh. So I think you're right. Sometimes parents may first report that my child's mouth breathing. And then you go, okay, so they sleep with their mouth open. But I think for me, the main symptoms to be watchful for is when the child develops continuous snoring. So you'll hear, but some parents will then say, oh, sometimes my child, I hear them have a snore occasionally through the night.
Yes.
It's very unlikely for that to be sleep apnea. So we call habitual snoring or primary snoring in childhood. That we see in up to 15% of children, so which is quite common.
Yes.
But as that progresses down that spectrum towards sleep apnea, what we'll start to see is the continuous snoring that happens through the night. And, parents say you can hear them snoring from the other room.
Right.
And then from there you hear other symptoms like they're just very restless during sleep.
They sweat.
That's right. They're sweaty. They toss.
Bed is messy.
Yes. So they're just really restless and tossing and turning. And then I think importantly to watch for those gasping breaths. So sometimes you can hear that. But sometimes you may need to see that. So I've had parents come to my clinic and they've had a video and they actually bring a video to me. And you can see the child snoring, and then pause. Yes. And then have that gasping breath. So I think, those are the key markers that would make me concerned that, we're progressing down that spectrum towards more of an obstructive sleep apnea. And then again, those daytime symptoms that we see in, children and adolescents around, they're just really tired in the mornings. Some of them complain of headaches in the mornings. Yes, they're not refreshed.
And temporomandibular disorders also kind of go hand in hand because you're tooth grinding and that parafunction during the night also relates to this.
Yes.
It's really interesting for me as someone that kind of sees patients that are showing these early symptoms, but always I've wondered, when do I refer and when do I not? Because, there aren't many of you in Adelaide. And of course, you don't want to waste your time with patients that don't need care. How do we know when something is serious and needs referral? And when should parents come to a sleep physician?
Yeah. Again, a fantastic question. So I think those warning symptoms, if we progress, I think into a more of a continuous snore as the first sign. And then if there's any sense of that gasping breath, I think that should definitely be followed up and referred on. But I think it's then those additional daytime symptoms as well, around just their tiredness in the mornings and, those behavioral issues during the school time and, and maybe even their learning effects or learning consequence of not having good quality sleep are probably the cluster of symptoms that I would probably alert a parent to raise that with their primary health physician to see whether a referral is required.
Needed or not.
Yeah.
Is it fair to say, because this is what I recommend to parents, is that just observe the day and the night and see how you go over the next couple of weeks and perhaps even take some videos because that might be useful for the physician to look at?
Absolutely, yeah. So I think, most children, again, every child goes to sleep at a different time in the evening, but if you do have the opportunity to maybe just watch for a few hours, sometimes at the start of the night or sometimes actually on the early hours of the morning.
Yes.
Just to put
the alarm on and go in and have a look.
Have a look. Have a look. And, I've known of parents who have set up, little videos in their child's room, just to capture some of those events because you never know when it's going to happen. And like I said, it typically happens during those REM phases of sleep. Yes. And if you look at a sleep cycle, that may only be 10 to 15 minutes of a 1.5 hour sleep cycle. So sometimes you may not capture those events, but I think you hear the continuous snoring through the night. And if you do capture those gasping breath, I think they're the warning signs that I think should be alerted.
If a child does have obstructive sleep apnea, what is the treatment for it?
Okay. So like I said, the most common age group we see are typically in the preschoolers. Yes. And the most common cause for sleep apnea in the preschoolers is due to enlargement of what we call their tonsils. So the tonsils are those little grape-looking things that are at the back of our throat. And essentially what they are lymph glands that filter infection. So if those tonsils look really large, and the other thing that also happens is what we call the adenoids. Yes. So the adenoids are essentially the same as tonsil tissue, but they lie right at the back of our nose. So you can't actually physically see that. By inspection, you need to put a camera in.
Or take a X-ray.
Absolutely, or X-ray the side of the neck to sometimes find that. But if you got big tonsils and big adenoids, that's the most common cause of sleep apnea in a preschool child. And at the moment, the gold standard treatment, if you are concerned about things, are to actually have those tonsils and adenoids removed, and they're done by a ear, nose, and throat specialist. But we also see another spectrum of children with sleep apnea, particularly around the adolescent years. And one of the growing concerns that we're seeing is a rise of obesity. You know, obesity is starting to be quite common, particularly through the Western world, and we see that more in our adolescent years. I think as kids tend to be more sedentary, they're spending more time on screens, less time doing exercise, and obviously, you know, they're picking on some fat-containing foods.
Of course.
So, and what we then see is a enlargement of a lot of that fatty tissue around your neck region. And due to that fatty tissue, then we see also the narrowing of the airway that then leads to sleep apnea. And what we find with that cohort of children, the adolescents, is they don't necessarily have enlarged tonsils or adenoids. They just have a lot of that, you know, that increased fat tissue. So we would always strongly advise around good healthy lifestyle, around maintaining essentially good weight and good activity and exercise, and good diet as well, because obviously weight loss would help a lot in those adolescents. But if there's a real struggle in that space, then one thing we do offer is a treatment using something called a CPAP or CPAP machine. Essentially what that involves is the adolescent typically wears a mask that's connected to a machine. And the way I describe it is like a vacuum cleaner in reverse. So a vacuum cleaner sucks. But what happens if this machine essentially blows air? It blows air.
Keep the tissues open.
That's right, through the night, and it keeps those muscles open in your airway to prevent that collapsibility of those muscles that we see in sleep apnea. So they're the two kind of main cohorts. We see the common preschoolers with big adenoids and tonsils, and then the adolescent cohort who unfortunately have put on a bit of weight.
And of course, from a dental point of view, the size of the jaws and the shape of the palate is also very important, because if the palate is narrow and the chin is receded or trapped back and hasn't reached its potential to come forward, then we have a smaller tube to breathe through. And of course, also the drape of the soft palate, what we call the Mallampati score, is also important, how much drape we have. So it's a anatomical issue, as well as the tone of the muscles as well. How flaccid they are and how collapsible they are. I've often wondered whether the obesity or the weight gain came because of the lack of sleep, or the vice versa, you know, because it's kind of a chicken and egg situation, isn't it?
Yes, it can be. What I think I've seen more and more in, unfortunately, our culture is the obesity typically precedes the sleep apnea, you know, and invariably it's you know, we do see that in families. But I think you're right in saying that, obviously the shape of the mouth, the size of the jaws, the receding of the jaw, and you say the descent of the roof of the mouth, all those things also contribute. And we do see them in normal children, but also we do see them in some children, unfortunately, who have a disability from a syndrome or genetic condition. And those children are definitely also at increased risk of having sleep apnea.
And we also see a trend towards smaller jaws, because we are not really getting into those really fibrous and really kind of a food that requires chewing, less breastfeeding rates as well, that doesn't grow the jaws as much as it used to. So do you see an uptrend in incidence of sleep apnea in children?
Yeah, great question. I think, the data from in Australia and probably broadly the Western world, because that's typically where the studies are done, probably hasn't shown a great uptick in the frequency of, or the prevalence of sleep apnea in childhood. I think it still hovers around that 3 to 5% that we see, in that preschool children as the key age group. Unfortunately, a lot of the statistics are not well measured in other parts of the world, the developing world. So it's hard to, get a clear feel as to whether there are any major global trends at the moment.
It's a very multidisciplinary field, isn't it?
Yes.
So there are several people that are involved in the treatment of a child with sleep apnea. Is that fair to say?
Yeah, I think, we very much rely on, those symptoms being recognized by a primary health physician or general practitioner.
Or dentist.
Yes, absolutely. A dentist, a very, very
we see
well
them
experienced
often.
dentist. And And then obviously from then, a referral is, hopefully put through to whether it's a sleep physician or sometimes directly to an ear, nose and throat specialist.
So I was going to ask, is it appropriate to refer directly to ear, nose and throat, or is it better to come to you guys first?
I think if you've got a very clear history with a very strong clinical suspicion, sometimes it wouldn't be, I guess, impossible to just go straight to the ear, nose and throat physician. Like I said, in that typical preschool age group, the large tonsils that you're seeing, those snoring, gasping symptoms. I think if it was my child, I probably, may lean towards going straight to an ear, nose and throat physician.
Yes.
Obviously, where we provide that additional service is really in the diagnostic pathway.
Yes.
But sometimes there are delays in some of those testing that we would love to do in children.
Yes.
And families are having to wait for, what would be invariably the gold standard of care.
Yes.
Which is generally removing the tonsils and adenoids. And some of the milder forms of sleep apnea, one of the advice we do say to families is a trial of some, what we call a nasal steroid spray. So essentially what they do is partially reduce any inflammation within your nostrils, but it may have an effect on just shrinking the adenoidal tissue, which, like I said, mentioned right at the back of your nose. So that has been shown to be of value in some children who have a milder form of sleep apnea. The challenge is trying to squirt a nasal spray out a child and having to have a cooperative child sit there and allow a parent to do that. That's one of the challenging areas. So I think if you look at just South Australia alone. So I think if I looked at the numbers, something like there's about 20,000 operations are done by ear, nose and throat surgeries, just remove the tonsils and adenoids a year. That's how many roughly it's done. But we are only able to really formally diagnose through objective testing between 500 children.
Parents often ask me, what's the cause of the hypertrophy of the tonsillar tissues? Any thoughts on that?
Yeah, so it's obviously where it comes from is a gland that filters infection. So we have gland tissue everywhere in our body, from our face, obviously, to those tonsils, to our chest, to our abdomen, throughout our whole body, those gland tissues exist. And typically what you find is families start to report initially a snore that happens in conjunction with an illness. Because what happens is, those tonsils have swelled up, because they're filtering the infection. So the first times you start to notice a snore is when your child's sick. But I normally say not to be too concerned about that. Let's just give a few weeks when the illness passes to see whether the snoring resolves, because those tonsils start to shrink back in size.
And some children are more susceptible to the swelling of these tissues. Is that correct?
I think it's it's probably where the size lies, rather the baseline. Some children just have slightly larger tonsils right from the outset. So obviously, it's a balance between how big these tonsils are and then the airway size itself.
That's right.
So what we do find in younger children is the airway sizes are smaller. So if you got enlarged tonsils, they do occlude a smaller breathing tube.
Yes.
But if like in an adolescent, as the airways increase in size, those tonsils
are not as large.
That's right. In relative size, are smaller, so they don't block the airway as much.
So this has been an amazing conversation. Any final thoughts or messages for parents, and as well as the general physicians and also the dentists that might be listening?
Yeah. So I think recognize that obviously sleep's a big part of our life. We spend a third of our life asleep. But I think just to be very mindful of those symptoms around those poor quality sleep. So if there's lots of just tiredness during the daytime, or a child who's snoring, or a child who has gasping breath, or a child who is playing up at school or struggling with their studies, be alert with all those symptoms. Be asking questions about sleep, around, comments around that sleep duration, but also the sleep quality. And if there's any concerns that are raised, please alert a general physician, and if necessary, a referral to a sleep specialist to help just explore that in greater detail.
Beautiful. And any message for the doctors? When do they refer?
Yeah, so I think just if you're uncertain about the snoring and the poor quality sleep, and you need further advice, please don't hesitate to refer on, because we'll be delighted to see these children and ensure that they have the best quality sleep to help them function well during the day.
Wonderful. Thank you so much for all the hard work that you're doing. And thank you for being here today.
Absolute pleasure. Thanks again for the invitation.